All right. In this particular review, what I am doing is basically going where the PowerPoints will tell you where the question is. Now, you need to comprehend that there is a lot of material over there. And even that I try to do my best to cut in most of the material, the file is a little bit extensive because you're supposed to be studying by your side. You're supposed to be doing your assignments in that notebook, and you're supposed to be reading from that book and watching the videos too. And with the grade that I am getting over here, well, I have that kind of in doubt sometimes. But let's go to chapter one. Chapter 1, levels of prevention. Primary, secondary, and tertiary. You saw this particular question in one of the quizzes. What are the levels of the prevention that we need to take? I will go with that particular question again, something similar for that, and that is the reason why I need to present this PowerPoint. Remember the primary, remember the secondary, and remember the tertiary, that is basically rehabilitation, okay? Meaning this particular PowerPoint signifies that is a question that engulf again those particular levels of prevention that we need to know. Let's go to the second presentation. In the second presentation, you remember that we have a question that created a lot of confusion in some of the classes about the incidence, about the endemic, epidemic. That is the reason that I am coming with the same kind of questions again, and the answer is in that particular PowerPoint. Meaning, don't confuse incidence with endemic and endemic with the epidemic. Please. That is a PowerPoint that basically will answer those kinds of questions. I have different kinds of questions for the same topic, meaning if you want to have that question correctly in the test answer, make sure that you understand all those concepts that you have in that PowerPoint. Endemic disease, native to a local region. Epidemic disease spread to many people at the same time. And pandemic spread to a large geographic area. And incidence, number of new cases that happen within a period of time. Okay? Meaning every PowerPoint that I was showing at this moment is VIP or extreme VIP, has been selected by me because they are part of the question that you will see in that test. Okay, that's why unless that I will make a mark like a something extra, I will not do it because I will make the assumption that all these particular PowerPoints are related to a questions in the test. Uh, this particular question can help you out to understand that previous slide because I did something similar to this question over there. That's why I put it out from the chapter 1. I decided to leave it over there in the review because that would tell you and help you out to guide you how to answer that particular test, okay? Or that particular question in that test. The next topic that I cannot escape, and we already advancing a little bit already, because this is basically almost chapter 2, is homeostasis. Many of the students have this particular question, right? I don't think that will be a discussions about this one. Normally, uh, where I saw a little bit of confusion was with the next one, but I want to make sure that everybody understands the two particular concepts, and there is a situation that normally they will confuse allostasis, that is the next one, with homeostasis. The question is from allostasis, okay? But I leave homeostasis presentation to make sure that you can compare one to the another one and don't fail for any kind of confusion when you answer that test, correct? Allostasis ability to adapt to those challenges, intricate regulatory process orchestrated by your brain, a dynamic process that remain or reestablish homeostasis in the light of the environmental lifestyle changes. Okay? Remember, I don't need to tell you they are VIP, they are extreme VIP because there is question related to this. One other question that you saw in the beginning of classes and the quizzes is the general adaptation syndrome. As you remember, I mentioned what corresponds to something that is alarm, resistance, adaptation, exhaustion. I need to come back again with this because apparently this one particular question are not clear in my students. I want to make sure that you understand what particular stage that an individual or that patient can be at any moment. Moving on immediately because it's where I will go a little bit more in deep. Fight or flight response and results of the stress for the stimulus. And remember again, this is a question that many students fail because they only answer me with the corticosteroids or cortisol, and they forgot that the hypothalamus influence the pituitary, and the pituitary influence the adrenal glands in that particular axis. Meaning, when you see again those three hormones from those three areas, this is the answer. Not the pituitary only, not the adrenal gland only, in the entire axis. And again, that's why I leave the same question over there, very similar, probably with another kind of topic, but it's basically the same situation. In the resistance, you see over there, or adaptation, activity of the nervous and endocrine system that return the body to homeostasis. And again, allostatic state activity of the different system that will attempt to restore homeostasis. I also leave this question over here because that can guide you. You already have the PowerPoint. You can do the exercise and trying to answer the question yourselves over there. And that will help you out to understand that I will go again with some particular question in regarding allostasis and homeostasis. Moving on immediately, I will go again with some particular questions of overload in allostasis individual, meaning allostatic overload cause of the body organs and the tissues for an excessive and inefficiency, basically, regulated allostatic response. That's the famous effect of wear and tear of the body when it has been under stress for too long. Meaning, I will go with that question again, very similar indeed. What happened to that person? Meaning that that is a question that will show up over there. Now, as a part of the general adaptation syndrome, there is some group of hormones that you need to keep in mind. And you have again norepinephrine. That is important because constrict the blood vessels and raise your blood pressure. If they constrict the blood vessel, obviously that is what will be the result, the increase in blood pressure. Also, reduce the gastric secretion and increase in night and far vision. Very important to remember that because there is another question in relation to this particular hormone that play an important role in the stress and adaptation. The other important hormone that we already saw, I hope everybody remembers, is epinephrine. Enhance the myocardial contractility, increase the heart rate, and increase the cardiac output. Causes bronchodilation over there, and also increase the release of glucose from the liver in a process that I asked you in one particular quiz, and I think in an in-class also, glycogenolysis that elevate the blood glucose levels. Moving on to the next one, you already have the introduction to the adrenocortical steroids that is important for maintenance of homeostasis that may synergize or antagonize the effect of the catecholamines, and you have the examples over there, the cortisol and aldosterone. That is the reason that immediately I will go over here. Cortisol is a question in your test. Again, it's part of the axis that I told you before. That's why I leave these particular PowerPoints over there to go a little bit deeper and avoid any kind of doubt and confusion when you answer that particular test. Primary glucocorticoids that affect protein metabolism, promote appetite and food-seeking behaviors, very important, and has anti-inflammatory effect. And remember, too much cortisol can lead to pro-inflammatory effect in a long time. The next one that we have over here that we will see also later on in the other chapters is aldosterone. Aldosterone, in other places, is known as basically the salt hormone because basically, give an order to the kidneys to reabsorb sodium. And so you reabsorb sodium, you will reabsorb water at the same time. That will increase your blood pressure. That's why you need to see that. Coming back to the allostatic overload, remember, I leave it over there to make my point that you have a question in the test in regarding that inadequate adaptation mechanism or excessive allostatic load and the inability of that person to maintain homeostasis. That is the reason that promotes some illness, disorders, physical and emotional, and the chemical mediator from the stress response that also make contribution to some illness like cortisol, catecholamines, and the cytokines. Now, until here, basically, that is part of basically was chapter 2, and then we jump to what is chapter 4. As you see over there, I am covering material from those first two chapters, what is essential, what is questioned in your test. I am not going with all the details over there, just what will help you out to answer that question in the test. In chapter 4, something that was a little bit problematic for me was how many people confuse atrophy with hypertrophy. That is the reason that I will go again with a question about atrophy. But to avoid any kind of doubt, that's why I included the definitions of others inside of this category to reinforce what you're supposed to know in case that you see some kind of doubt in the information in the question, you know that that is atrophy, that is hypertrophy, and that is dysplasia. Again, atrophy, cells shrink and reduce their differential function in response to normal injury factors. Now, what are the causes for this? And that basically is a question that we saw recently by the use and innervation, could be by ischemia, could be by nutrient starvation, interruptions of the endocrine signals, and persistent cell injury. Very important indeed, because when I do the case study, I will go with this particular wording over there, and you need to tell me what kind of problem that person is suffering. Make sure that you don't confuse general causes of atrophy. Now, to avoid confusion, and that's the reason that I will put these PowerPoints over here to study, is hypertrophy. Increase in cell mass that goes with a huge augmented functional capacity in response to physiologic and pathophysiologic demands. What is the general cause over here? Increase in cellular protein content inside of that muscle. Very important to avoid to confuse one with height atrophy and with hyperplasia, that is the next one. Hyperplasia, increase in functional capacity related to the increase in the cell number because the mitotic division. That is different from hypertrophy, obviously, because we are not seeing over there what? In a huge cell mass augmentation. What we see over here is an increase in numbers of cells that are in division. That is the difference between hypertrophy and hyperplasia. Careful with that in case that you confuse that question there. That is the reason that I want to have over there. I have a question over here from Juan. What happened, Juan? You can make the question to the box over here. Or if you want to say something for everybody to hear, you can go ahead. No? All right. Meanwhile, Juan make the question. Let's continue with the next one. Dysplasia. This is one of the most simple questions that we saw before. And for some reason, I put the question as a blank, and many people put so many things over there in that blank. And that's why I will go with this question again in the test. Dysplasia, disorganized appearance of the cell because the abnormal variations in size, shape, and arrangement, and represent an adaptive effort that goes out of whack, out of the way, significant potential to transform those cells in pre-neoplastic lesion or cancerous cells over there. Careful with that because I can go with that again. Now, I am jumping to the next topic that I asked you already, one of the quizzes and also in the in-class assignment. Yeah, I will go again with this one. As you see over there, that I will ask for dry gangrene again. Not everybody will get the questions of dry gangrene. I will tell you right now. Some people will take the wet gangrene, the gaseous gangrene, but that is the reason that I need to include all these PowerPoints over there because if you study them, no matter what is the question that is in front of you, you will be able to answer it correctly. Meaning, dry gangrene is there. Form a coagulative necrosis characterized by the black, dry, wrinkled tissue separated by a line of demarcation from healthy tissue. That is the key in dry gangrene. I need to say dry in dry gangrene. So you see that, and so you see the demarcations in the tissue, in that description, in that question, you know that you have in front of dry gangrene. The next one over here is the wet gangrene, typically found in internal organs. Very important to remind you that. Form for a liquefactive necrosis and could be also lethal. The next one, gas gangrene, result from infections of the necrotic tissue by anaerobic bacteria, characterized by formations of gas bubble, and that is the key with the gas gangrene. If you see dry in one side, you already know that is gangrene. Sorry. If you see the gas bubble, gas gangrene. And see you have over there the liquefactive necrosis, we are informed of wet gangrene over there. That is the way how to pick them out when they are asking you that question in the test. Again, not everybody will have the same questions about gangrene. There is two different questions about gangrene. That is the reason that it's better to study the three of them to avoid any kind of doubt and confusions in the test. Now, even that I don't ask you about this one, I decide to leave it over here for one main reason, and it's because when we reach to the chapter of the heart, we will see these particular problems in the heart related to hypoxia and ischemia. And I want to make sure, especially with that second bullet over there, that everybody understand that ischemia is the most common cause of cell injury and injury cell faster than hypoxia alone. That is the only reason why I let this PowerPoint over here, because that is essential when we will see what happened to the cardiac muscle in response to the ischemia. Okay? Again, I leave it over there just thinking to reinforce what you need to know when we reach to the chapter of the heart. Let's move on to the next one. Now, many persons have problem with these particular mechanisms of cancer. As you see over here, I am advancing to the chapter because not all the things that I want to ask, I can ask. It's only a test of only 50 questions. You have proto-oncogene and oncogene and tumor suppressor gene over there. Many, yes, that is correct. That is why I am coding very quickly in all the chapters over there. That is what I want to show you, that I am putting away huge amounts of material to focus where the questions is, okay? Now, it's up to you. Don't wait until the last moment to review the review, because it will be too late to go through all these PowerPoints that I prepared for you today. I have 170 and counting because I'm pretty sure that I need to ask something else before in one of the breaks over here is over to make sure that every question and every information that you have over there can answer those questions in that particular test. Again, proto-oncogenes and oncogenes and tumor suppressor gene. Remember, these fellows over here are the good guys. If for some reason the other oncogenes start to basically became activated, at the same time the tumor suppressor gene became inactivated, is when we have the initiations of a cancer cell. That's why I leave this one behind over there, because you need to understand again what is proto-oncogene, what is an oncogene, and what is a tumor suppressor gene. In the next one, you have the most common important tumor suppressor gene, the P53. That is the reason that I leave it over there. Many students confuse this one in one of my quizzes also because they forgot exactly this part over here, especially about the DNA damage. And that's why I put this one back over there because there is a question hanging in one of the variants of the test that we will ask you about the P53 again. Okay? Meaning keep that in mind. When I see that there is a lot of students with a particular information with problems, I will try to ask those questions again. Now, you see over here how we are jumping to the hypersensitivities, and we already mentioned that we have 4 of them. I cannot ask you the 4 of them, but I can ask you at least 2 of them. And one of the first one that I will ask you is about type 1 hypersensitivity, meaning you will see it, is there, and one of the main reasons for that is because you already know that that immunoglobulin E is very important in these particular kinds of hypersensitivities. When we see asthma later on, we will basically revisit again these particular hypersensitivities because it's highly related to asthma in particular, meaning involved in the ability to respond to the antigen and to produce the immunoglobulin E antibody in response over there. Usually, you always have high levels of IgE in these kinds of reactions. Let's go to the next one. The pathogenesis, obviously, the reaction happens after maximum amount of time of half an hour of exposition to that antigen and allergen. IgE is principal mediating antibody in this particular reaction, and the mast cells and the basophils are the principal effector cells for this one. You already know that I asked you about these fellows and the particular work that they do and the particular task that they do to release by degranulation this particular signal. Okay? I will not ask you that particular question again, but you need to understand that over here in the hypersensitivities one, the IgE over here is the principal mediating antibody in these kinds of reaction. Moving on over there, I need to ask you something about histamine, obviously, because it's the most important mediator in hypersensitivity, is the category 1, meaning basically that is what you need to know right now. I will not go with the rest over there, just to remind you that the histamine is the most important mediator over here in the type 1 hypersensitivities, okay? I will move to the next. Immediately, I am jumping to the type 2. I need to tell you, I have a question about type 2 in the test, meaning everything that is over here, need to make sure that you understand everything here. Remember, this particular hypersensitivities, what you have over here is what? An antibody attack antigens on the surface of the specific cell or tissues causing the lysis of that particular cells. And the cell lysis over here may be mediated by active complement fragments or membrane attack complex. That is something that you need to know in case that you encounter that question in one of the tests, because there is 2 variants of the same question. And you need to be careful how to identify everything that is inside of that particular area over there. Okay? Moving on over there to the next one. Another example of the type 2, exactly what we saw in one of the quizzes, transfusion reactions, and we already have a better idea what's going on over there. The individual mismatch with the donor red blood cells antigens that could happen. It's not frequent anymore, but it still could happen because we still discover different kinds of antigens in individuals that can make these kinds of reactions to happen. Another example of the type 2, hemolytic diseases of the newborn. And the reason that I put this one over here is because if there is a case study or a question in the test that relate to these particular cases that you see over there, you understand that we are in front of a type 2, not type 1 or type 3 or type 4. Okay? also called Erythroblastosis fetalis. Everybody remember this one very well. Mother negative Rh, baby positive Rh, and you know what will happen with this baby, especially in the second pregnancy, that the mother will create those antibodies against the blood of the baby, and basically is almost lethal for the baby. Another kinds of diseases that we see with the type 2, myasthenia, and the grave disease of the lymphocytic thyroiditis. Very important to remind you that one, because I need to tell you, in the test, I will put some of these diseases that you have over there, and I will ask you what kind of type of hypersensitivity is, meaning you have it in front of you. Careful with this one in particular, but every one of them will be related to something over there. Moving on over there. In the type 3 over there, also known as an immune complex reaction, immune and phagocytic system fail to effectively remove the antigen-antibody immune complex, and is not tissue specific, meaning that they don't have any predilection to attack any particular tissue over there. Okay, let's move on over there. To Andy, I don't have your test message, just in case. Double check your cell phone number, the one that you have for me. Deposits of the antigen antibody complex tissue result in activations of the complex, self-sustaining inflammation, happen after several hours or longer, usually ongoing over there. The reason that I leave over there this particular slide is to make sure that you don't confuse this one with the type 2 or the type 4, okay? But again, the question is between type 1 and type 3. I don't put type 4 in the test. I want to make clear that right now. In the possible etiologies, you can have person with recent history of infections or persistent low-grade infection by microbial or viral agents, an extrinsic environmental antigen from molds, plants, or animals, can be inhaled to the lungs. Yes, that is correct. 1 and 3. 1 and 3 is basically some of the questions that you will see, and there is a variant for number 2. But normally, for everybody over here, beware. The answers are related with type 1 and type 3. The problem is that I can confuse some of you if you don't read this particular PowerPoint with some characteristic of type 2, okay? Even that we saw type 2 already in one of the quizzes and in the in-class assignment. Now, an autoimmune process can develop in which the autoantibody attack the self-antigens. I leave it over there just with the finality to make sure that everybody is reading and understanding this one that is part of your test in next week. And the mechanisms of injury, activations of the complement and other pro-inflammatory mediators in response to the antigen-antibody complex. That's why I want to avoid confusion with this. The antibody-antigen complex deposition do not cause the injury. Very important to remind you that. Now, inside of the type 3, we have the systemic lupus erythematosus. This is a beautiful example that will show up in your test like one of the type 3, meaning careful with this particular PowerPoint because could be directly to answer that question that you will see in some of your tests over there, okay? Remember, and very important over here is this, the individual develop antibodies against nuclear antigens like DNA, DNase, and RNAs over there. That is the reason that this particular disease can be a little bit difficult to diagnose. Now we are jumping to another chapter, basically, over here, classifications of hematologic neoplasm. Something that many people fail for this, I would say over there, a tiny trap in the test is because I managed very smart to change myeloid by lymphoid in some particular question, and everybody fell for that. meaning you need to make sure what I'm asking you before you jump to answer, because if you see the 3 cell, but then I put myeloid lineage, that is a false statement. And that is what basically happens in some of the multiple choice in the quiz over there, in the test last week over there. Meaning, make sure that myeloid is one thing and lymphoid lineage is another thing over there, okay? That's why I put it over there as an introduction, but I will go more with this one right now. As you see over here, this is a little bit more deeper. Myeloid neoplasm again, and lymphoid neoplasm again. I will go with these fellows, and some of them I will go exactly what I did in the quizzes with a little bit of more details inside of them. But this one, this particular PowerPoint at least can make you differentiate between one group and the other. Later on, I will go to some of particular of them again because they're important for me that you still remember in your beautiful profession. Let's move on. We had the first one over here, the chronic myeloid leukemia, the pathogenesis and clinical manifestation. You already know that represent 50% of all the cases over here, but only happens in childhood and the adolescence. Sometimes I can do a true or false and make you think that this could happen in another age or another sense of group over there. But remember, the onset always, and you see it over here, 40 to 50, yeah, I can make basically an idea that this particular disease can show up in toddlers or childs mainly, not in this particular onset. That's why you need to be extreme careful to make sure that you are in front of this one and not in front of the other ones. More about this one, and this one was a particular one that many people confuse in the test because I put over here, I think was lymphoid instead of myeloid. When I put lymphoid instead of myeloid, everybody saw that is the correct answer, but it's not. That was the false statement. Obviously, this particular leukemia, the cardinal point, I mentioned this one in the class, is exactly this, meaning no other leukemia is related to that. That is the reason that I will put this question again. Another variance of the question was exactly this over here, create a new fusion with the gene that I put in some other questions over there, meaning that I put the slides over there because the two questions can show up and are showing up again in your test next week, okay? Careful with that one. Over here, you see the pathogenesis and the clinical manifestation, and the cell have greater degree of segmentation than the other ones in AML. Usually clinical presentation, high granulocyte count on the CBC and the splenomegaly that you will see in this particular presentation. Okay, that's why I leave it over there in case that you will see another leukemia with more information and avoid confusion between them because I am asking almost all of them again. The symptoms, they are very common in between them. I put them over there just to help you out to remember some of them, but I am not asking directly this one, just to help you out to answer the question when you see some of them over there, okay? Now, the treatment, it is important for me because the CML do not respond well to the chemotherapy. That is why I put it over there. In case, in the case study that shows us in the test, I ask you for that, or I present something like that. You already know what kind of leukemia I will try to ask you over there in the question. That's why I leave this one over there, but not for nothing else, okay? In the prognosis and treatment, I basically leave this one over there to remind you about this particular thing, about the genes therapy that we are using because it's very similar to the answer to that previous question. The other part over here, I will not ask you, meaning careful with that particular first bullet in related to the prognosis and treatment of this particular leukemia. Now, in the acute myeloid leukemia, I will ask for this one. Remember, over here, what I want to ask you and make sure as you see that case, because there is a couple of questions similar, is 80% are adults and median age is 64 years of age. When I make these case studies, those questions in the test, I would tell you this is a person all age with 80 years of age, blah, blah, blah. Then I would present the case and the manifestations of this particular leukemia or this particular disease. That is the reason why you need to understand that these particular details over there are important to make the rule out of the other particular diseases. I move on to the next one. In the pathogenesis over here, so the only thing that I like to ask is the second bullet over here. The most common type of AML, acute granulocytic leukemia, often used over there, like interchangeable with AML over there, but that is the reason that I leave this one over there because it's the most common type, and this is something that you need to remember always. In the pathogenesis over here, I basically leave this one over here because of this subtype according to the genetic abnormality that they are showing. Worse outcome, obviously, if they don't have those particular genes over there functioning correctly because they're more aggressive, this particular leukemia it is. Meaning, careful with that. Only that is what I will basically put in some tests over there. In the prognosis, worse. That's what you need to remember. In the acute promyelocytic leukemia, I don't ask you about that one, but the prognosis of this one, yes, meaning that is the second bullet that you need to pay attention. In children, less than 50% children, 20% in adults survive long term. That's why I ask you for this particular information because it's important to know what we have in front of us. Meaning, careful with that second bullet only that is related to the question. In the next one, you already know the famous chronic lymphoid leukemia, basically 30% of all the cases of leukemia in the United States. Now, 95%, this is what you need to remember, are malignant B-cell precursors, follows an indolent course. That is basically a good description that I can make you in the case study. Asymptomatic, that is another clue over there that you are in front of a CLL, and usually found by accident in a routine blood examination. Normally, I don't ask you for that, but the first over here, 95%, and that's the first bullet over there that is indolent and course and asymptomatic is important for me. Careful with that particular bullet in regarding the chronic lymphoid leukemia. In the symptomatics, basically more or less is the same thing. The only thing that I want to add to the previous one is this part over here. The malignant lymphocytes invade lymphoid tissue and bone marrow and disrupt function. That is the reason that they enlarge painless lymph node and enlarge spleen over here. That can create confusion with another pathology that we will see soon. Meaning careful with that part over there because it's part of the question. And basically, we have in the bone marrow infiltration, but here what I want to show you is this, that the CLL characterized by the defective apoptosis and longer lifespan. That is why you probably need to remember for this particular question to avoid confusions in the test. Nothing else there. Now, in the other kinds of acute lymphoblastic leukemias, lymphomas, remember that the pathogenesis over here is a malignant disorder of the lymphoid cell lineage, not myeloid. Careful with that. I like to trick you out with these kinds of wording over there because you need to pay attention what I'm asking you. 80% will result of malignant transformations of the B cells and 20% involved on the T cell. And normal cells are lymphoblasts and they look like immature lymphocytes. That is essential to remember in that question in your test. In the pathogenesis, present as leukemia, but the lymphoblastic leukemia are the same disease, just different stage. I will not tend to ask you for that, but what I like to ask you is this. All primarily are children disorder, most common malignancy, second leading cause of death in this population. That's why I need to ask you for this. And the peak incident between the 3 and 7 years of age, and second peak in the middle age. Careful with that. Meaning, this is the part that you need to basically go to look in and read again. In the multiple myeloma, basically, also known as a multiple myeloma over there, you have the malignant disorders of the mature antibodies secreted B cells. Happens exclusively in adults. Sometimes I trick you out and put over there children. Careful with that. Usually over 40, median age 65, and they predominate more in the gentleman than in the ladies. But again, careful with that second and third bullet over here, because it's the one that I will attack in that particular question. In the pathogenesis, we have over there malignant plasma cells invade the bone marrow and form multiple tumor sites, may also target other tissues, including lymph node, liver, and spleens, and kidneys. That's the problem with this fellow. They tend to spread also to those other organs over there. In the abnormalities over here, basically what we have in the chromosome is destruction commonly found, but what I will ask you for here is the second bullet. Malignant plasma cells produce excessive identical monoclonal antibodies that basically accumulates in the bloodstream and it by some particular serum protein electrophoresis. Large amounts of one type of antibody will form a characteristic spike in that particular test. But again, this is the second thing that I will ask you from here for the multiple myeloma. The huge amounts of identical monoclonal antibodies that these particular fellows produce. Again, something for some reason many people have wrong, or many times in this particular one. Remember, multiple myeloma, very associated with the Benz-Jones proteins. I told you that in a review, and the people still should go with the Restenberger in the non-Hodgkin. Okay, please don't commit that mistake again. I will go with this particular question again. That is the reason that I leave it over there, because many people had this particular information wrong. I will go with this particular question because of that. Make sure that at least you remember them. Again, these particular things can accumulate in the kidneys and damage the kidneys by accumulations of particular fragments of those antibodies. Moving on over there. In the pathogenesis and the clinical manifestation, the diagnosis, monoclonal antibody peak, the presence of that protein that basically was the answer in that particular quiz, the bone marrow biopsy confirmed by diagnosis, but I will not go over there, just basically to remind you again, the presence of that protein that is characteristic for the multiple myeloma in these particular cases. Moving on. There is something that will show up and is related to this monoclonal gammopathy of undetermined significance. It's a pre-malignant stage that some individuals can have because they don't produce the lesion or don't have the Benz-Jones proteins in the beginning. Meaning that, careful with that, is just a curiosity in the question that probably I will mention something like this or completely the wording, and you can become confused because you can think that is something else. But I am talking about the same thing, multiple myeloma. Okay? In the pathogenesis over here, I will have over there just one thing to tell you is the bone marrow depression indicators that will give you anemia and also bleeding tendencies, obviously, in that particular area. Okay. Moving on to the next one. Now, the renal problem, you will see it over there, 50% related to multiple myeloma. That's why I want to make sure that everybody remember this in case that they see that in that case study. Some of the question, in some of the variants of the question, will tell you that they have a problem in the kidneys. As soon you see problem in the kidneys, and as soon you see problems with that Benz-Jones proteins, you already know that I am in front of that multiple myeloma. Okay, that's the key. How you read the question, how you pull out all these particular details that will give you the answer to that question. Okay, moving on. Finally, we reach to the Hodgkin disease. Many people confuse this one and they immediately put none over there, and they tell me yes, that the non-Hodgkin had the Rita-Sternberg cells. We mentioned that one several times, that the Rita-Sternberg cells is just in just Hodgkin disease, not in just Hodgkin disease. Okay. Yeah, we'll go with that question again because that reason. Many people confuse this particular question because the Rita-Sternberg cells. Okay. Meaning careful with that again. I will go with this part again in some of the tests. Not all the tests will have the same question, but there is a group that will be there that questions again. Probably some people will have the non-Hodgkin disease and some other group will have the Hodgkin disease. That's why I put both slides over there. In the pathogenesis, very important indeed because I like to mix this one with the non-Hodgkin. Careful with that. That is basically what I ask you. And the final one over here, inflammatory cell accumulates in the node. Red Sternberg cell constitute around 2% of cells in lymph node and tumor. The Epstein bar, frequent found in the genome that transform these particular cells, and maybe be important for the pathogenesis in the Hodgkin disease. Moving on over here. In the pathogenesis, careful with this. Many people also confuse this. The painless lymphadenopathy, possible with fever, night sweat, pruritus, weight loss, and malaise. You could have a lymph node enlargement above the diaphragm and even cervical node, most common site, but that doesn't mean that the non-Hodgkin will have several similar presentations. That's why it's essential that you will never forget that the Rita-Sternberg cells just only apply to the fellow. Okay? Moving on over here. Now we enter to the non-Hodgkin. Again, do not have Rita-Sternberg over their cells. In that beautiful in-class assignment that I asked you to make the different one to another one, that's what some student did. Yeah, yes, no, the Hodgkin don't have this and the other have this. And you see over here how many difference they have between one to the other one. And that's the reason that I put this one again. I will ask for non-Hodgkin again to make sure that everybody remember the difference between these two. And the majority arise from lymph node, but they can originate in any lymphoid tissue. 95% happens in the adults. Very important to remember that. Males somewhat higher than the females in this particular category. And then most arise from the B cells, T cells, and the natural killer cells. Remember, the reason for that is because they are lymphoid tissue. If you see that I said that the non-Hodgkin arise from the myeloid tissue with the B and T and NOR killer cells, that is a false statement. Careful with that. You need to understand that myeloid is one thing and the lymphoid is another thing. Let's move on to the next one. In the pathogenesis and the clinical manifestation, see that is very similar to the other malignancy. That's why many people can become confused. But there is something that is very characteristic of this fellow, and is this. Many people remember this one already, the Burkitt lymphoma. The tumor cells derived from a single mutant precursor cell are clonal, and 5-year survival rate is 75. That have a good survival rate in this particular area, but this is the characteristic, the Burkitt lymphoma. Let's move on over there to the next one. Now we jump to the next chapter. You see that I am coding. I'm trying to summarize as much that I can. Just focus in the question that will show up in the test. We have now the erythrocytes over there. Uh, the reason that I leave this particular PowerPoint is because the tiny disaster that we have to remember the range of every particular group of cells in the body. And that is the reason that I put this one over there again to remind you what is the normal range of the red blood cells over there. All right, let's move on to the next one. Okay. All right. Okay. Now, the next one is what the erythrocytes do for you. Remember, the erythrocytes buffer the blood pH, may have or they have a very important constituent that is hemoglobin. Also have an interesting enzyme that is called carbonic anhydrase. That is the way how the CO2 combine with that beautiful red blood cell and carry on this fellow through the system. The next one where we have is the leukocyte. And the reason that I leave it over there is not just other than the range. If you have more than 10,000, that is leukocytosis. If you have less than 5,000, leukopenia. For some reason, I don't understand why, we have many nurses that they don't know how to recognize that value that is so essential to tell me if that patient have an infection or not. They forgot this one in the quiz. You need to remember those values in your memory always, because this is what will tell me what you have in front of you. Is an infection? Is this an infection? Is acute? Is this acute? Or is viral? Or is not viral? That is the kinds of thing that these particular values will tell me. Meaning, you need to remember that. That is the reason that I left behind this particular PowerPoint, because I will go with the same question that I did recently to tell me if this is anemia, if this is polycythemia, if this is leukocytosis, if this is thrombocytopenia, or if this is thrombosis, because that is important. Again, the value of the platelets over there, that is the main reason that I leave this one over there too. Anything that is below 150,000, below 150,000 is thrombocytopenia. Anything above 400,000 is thrombocytosis. Meaning that for me is one of the most easy questions that you can catch in the test, meaning make sure that you are remembering those particular range, because I will go with that question again. That's why I leave this particular fellow over there. Now in hematopoiesis, the reason that I leave this particular PowerPoint, and you already assume why, is because your beautiful friend erythropoietin, the hormone that the kidneys produce in response to hypoxemia to stimulate the erythrocyte productions in the red bone marrow. That's why I need to remind you that, because that also play an important role in another kinds of situations in the circulatory system. Now, exactly what I mentioned before, to have erythropoiesis in your body, you need to have some requirements of nutritional requirements, a huge adequate amounts of irons, proteins, vitamins, minerals. Also the folate and the famous B12 that can be impaired in these particular persons, DNA synthesis, and in erythroid cells, because the vitamins are coenzymes, are key reactions in cellular metabolism. And the absorption of B12 requires the intrinsic factor produced in your stomach. Also, that is basically give you the idea why you can suffer the anemia that most of you already know, pernicious anemia. That is the one that basically associated with the lack of B12 over there, okay? We didn't went direct and deeper in this particular pathology, but remember that the B12 help you out to absorb lipids. And lipid is very essential for every cell in your body, especially for maintenance of that myelin that the neurons possess in your central nervous system. If you don't absorb fat, there will be a deterioration of that myelin over there, and that person mentally will start to deteriorate, and there is some neurological changes in response to the lack of B12 in this individual, meaning that even at that level, a huge deficiency in B12 can trigger mental issues too. Just to give you an idea how deep this goes. Moving on over there. This one I ask you in some of the quizzes, the affinity of the hemoglobin for oxygen is affected for these particular fellows. Some people will see this one as a true or false. Some of you will see it as a multiple choice and you need to pick all of them, not only one. I put it over there to see if somebody was reading that slide, but apparently not. Meaning that careful with this one. In some of the tests, that question will show up again, and there is many of them over there that could be or true or false or multiple choice. Now, this is a question that I will ask now for the test, and it's related with this particular area over here. The carbon dioxide will be transported in the blood by dissolved gas, bicarbonate ions, and bound hemoglobin. Interesting is that I have three variables of the same question, meaning that I eliminate two of them and just one is the answer. In other questions, obviously, the answer is this one and the answer is this one, meaning that make sure that you remember the three of them because you don't know which particular question you will get that will answer that question, okay? That is the reason that I put it over there. I am specific. That is a question, and what those over there are the answer to those questions. Let's move on to the next one. The carbon dioxide transport. The red blood cell contain the enzyme carbonic anhydrase. Very important for me over here. Greatly increase the conversion of CO2 and water into bicarbonate and hydrogen ions and the tissue levels and can cause the chloride shift, meaning this for me is important too. In one particular case, you need to know that to avoid any kind, of doubts. Remember, it's that enzyme that makes this possible. It's the only hint that I will give you over there, okay? I will move on to the next one. And then we are reaching the anemias. And you remember that I asked you for a group of particular sentences that you need to tell me what kind of anemia it is. I discovered that we have a little bit of doubts about those particular topics. That's why I will ask you again some of these particular anemias. Remember that the plastic anemia over here, the insidious onset of the symptoms. This is a good key when you are trying to answer that question. The late symptoms is very similar. That's why I will not go over there. But the thrombocytopenia and neutropenia, from infection, is another element that is important over here. Meaning, when you have those particular elements together, you are in front of aplastic anemia. Okay? Again, my favorite is anemia, the pernicious anemia, the anemia because the lack of B12. I will ask you that, because this trigger a lot of problems in the individual, in the system. You see all of them over there. It's one of the most important anemia that we have in medicine. That's why I will ask you that question again, no matter what, because it's something very common indeed. Okay? The other kind of anemia that we see normally, the most common nutritional deficiency in the world, the most important, lack of iron for hemoglobin synthesis, hypochromic, microcytic red blood cells over there, and you have the values over there in size of that particular red blood cell. Remember to review all those beautiful fellows over there. Okay? Serum ferritin level decrease, serum iron level decrease, total iron binding capacity. Also important to remember that. Many persons forgot what exactly was that, and they are telling me that basically it was another thing, meaning that careful with that particular question because, again, everybody will not have the question for the same particular anemia because everybody will have a different anemia in the test. That's why I put the slides that are related to the anemias that are coming in your test. Okay. Thalassemia is another situation that I want to remind you because we have a lot of patients with this. Increase in red blood cells over there, destruction, hemolysis resulting in decrease of red blood cell survival rate, associated with a mutant gene that suppress the rate of globin chains over their synthesis, and the chains S deficient synthesis, but that's why you have the alpha thalassemia and beta thalassemia, and the most clinical severe over here is the major. And many people confuse this one with sickle cell disease. It's not the same, meaning the careful of this one, that's why I leave it over there again. Okay, moving on over there. Thalassemia, hypochromatic, microcytic over there, the corpuscular volume, the hemoglobin corpuscular volume over there, all of them over there, concentrations of hemoglobin for corpuscle, and the erythroblastotic hyperplasia in the bone marrow. The only reason that I will ask you over there, this one, or I leave this one over there, because I like to include in the question these particular details. If you see it over there and you associate that with anemia, you already know that I'm talking about this particular case of anemia. That's why I included to make sure to reinforce what you need to know. Then polycythemia. What I will do at this moment, I will make a tiny pause over here because it's 1 o'clock and I already recording for 1 hour. I don't want to extend myself, okay? I will give a break of 5 minutes and then I will stop the recording now just to make sure that we